So it's my pleasure to introduce our first and keynote speaker this morning. Ann Greiner is the President and Chief Executive Officer of the Patient-Centered Primary Care Collaborative, or PCPCC. She is responsible for leading the overall organizational strategy, fostering strategic partnerships throughout the healthcare sector. With over 60 member organizations, PCPCC is focused on research, education, and advocacy to further a comprehensive and team-based approach to patient-centered primary care. Ms. Greiner has over 25 years of experience at national and not-for-profit organizations, many of those as a senior-level manager. She held high-profile positions at the American Board of Internal Medicine, National Academy of Medicine, and the National Committee for Quality Assurance. Ann has a master's degree in urban planning from the Massachusetts Institute of Technology and a Bachelor of Arts degree in English Literature from Hobart and William Smith Colleges. Ms. Greiner will present today on dental care, on the pathway from volume to value. Please join me in welcoming Ann Greiner.
Well, good morning, and thank you very much, David, for that introduction and for the invitation to be here with all of you today. It was really exciting to hear about the American Institute of Dental Public Health. You are already way ahead of the curve in your approach of bringing together all the professions in linking with oral health with the community and a focus on public health. And I understand, too, that there's already a lot of innovators in the room, given your exposure to value-based payment. And I view that term really as code for transforming the delivery system to get to the kind of outcomes that we all want for patients. So VBP is just a shorthand. And I really appreciated the remarks about the dental revolution. So that was very inspiring. And you're wearing your red, so clearly you're ready for the revolution. So let me start by giving you a sense of my remarks. Ooh, here we go. I'm going to really chunk this presentation into three different areas that are all interrelated. I'd like to start with a little bit of a chronology of how we evolved, and we are continuing to evolve, value-based payment on the medical side, because I think that context can help all of you as you think about it in the oral health arena. And then do a deeper dive into how the Patient-Centered Primary Care Collaborative, the organization I lead, has helped to transform care for primary care, because I think there may be some lessons there. And then we'll get to oral health and think about how the broader context and our particular focus at the Patient-Centered Primary Care Collaborative in transforming primary care may have some lessons and insights for you all in your transformation journey. And I am not seeing my slides, which I was supposed to see. I've got, here I've got the Slido, which I'm a huge fan of Slido. So I'm wondering if our friends in the tech world can help me with the slides here. There we go. Thank you so much. We used Slido at our last two meetings, and it really is a way to democratize, I found, the exchange, because there are people in the audience who, are very comfortable raising their hand, and, they're the folks you always hear from, and then lots of people who, have a question, but it's just difficult to be that person to stand up and pose it. So I found that Slido really does help democratize the conversation, and also it's wonderful in terms of a great way to gather all that data for your proceedings later. So hats off to you all. The history of value-based payment, I think we really need to start with performance measurement, which is the guts of value-based payment. Because if you're going to pay on the basis of value, how do you define value? And performance measures are how we define value. And it's where I got my start, actually, in the healthcare arena, working with the National Committee for Quality Assurance on the first performance measures for health plans. And they really were based on the Healthy People goals. So performance measurement began in the medical side really in the 1980s, late 1980s, and they hearkened back to the Healthy People 1979 goals. And so I was curious, what did those Healthy People goals, which were focused on prevention and the first ever goals that the US had, what did they say about oral health? And it was interesting. There were 4 goals about oral health. There we go. And so I'd really ask you all to reflect how much has changed in the 40 years since those goals were promulgated. Tooth decay, well, certainly there's been a whole lot of effort to improve access for the pediatric population with respect to addressing oral health issues, and congratulations on the work that was done to expand coverage through CHIP and the ACA, fantastic. Annual dental visit for adults, I sort of saw some contradiction in the literature that I looked at. Either it's flat or maybe it's gone down a little bit for the under 65 population, so I'm not exactly sure. You'll help me to understand that. Community water supply fluoridation, clearly major gains there. And I think CDC has noted that as one of the 10 top public health successes. So that, congratulations. And interestingly, this 4th goal is really about what my talk is about today, about this integration of primary care and oral health. And it was an initial attempt that dentists should be providing dietary guidance, and primary care physicians should also be urging their patients to get dental care. So the beginning notion 40 years ago about some kind of integration. It just goes so quickly, sorry. So how did performance measurement really get, what was the catalyst? And interestingly, it was the Clinton healthcare reform plan, which we know failed. But Clinton proposed that there would be report cards that would be a part of the Clinton health plan, and that providers, health systems would all be competing on the basis of performance, and this would have a transformative effect. Well, we all know that that plan didn't go anywhere, but what happened as it was being debated and discussed is that the health plan said, oh my God, we don't want the government to do this to us. We're going to start reporting quality measures. And HEDIS, which is still the standardized performance measurement set that the National Committee for Quality Assurance holds, it got a huge mental lift because of the Clinton health reform plan. And at the time, because I was actually at NCQA, we believed that if we just put information in the marketplace, it would have this incredible transformative effect, that it would change the behavior of physicians and hospitals and payers and patients. Everybody would get this information about cost and quality and make a different set of selection decisions, and their behavior would be different because they'd be competing on value. Not so much, right? Yes, transparency is and was a very important movement, but it was not transformative. And we really began to understand that with the IOM reports. I was also at the National Academy of Medicine putting those reports out, and the public and really all health professionals began to understand that our system was fundamentally broken, that it was going to take more than transparency to really transform it. And so we began to understand that it was going to be not only better and information about value, but also we needed to change delivery and we needed to change payment. At the same time, in oral health, the Surgeon General came out with a report about the silent epidemic of oral health issues and really describing the systemic issues that needed to be changed. And so I think collectively, both in the medical sphere and in the oral health sphere, there came to be this understanding that there needed to be whole-scale transformation in order to get us to a kind of system that would be higher value, better patient outcomes, and lower cost, and much more satisfying for patients. ACA was the most consequential healthcare legislation ever. I know it didn't really speak to oral health beyond, it didn't speak to oral health much beyond a provision that in the essential benefits that helped to expand dental care for children. It did a lot on the medical side, a whole lot. It helped to further and fund a lot of value-based payment programs for every sector. And since then, bipartisan bills have built on that. It set up a lot of investment in the National Quality Forum with a whole array of efforts to standardize performance measurement. I did a look at the 1,000 measures in the National Quality Forum database of endorsed measures that are used by the health, every sector of the health system. Anybody want to tell me how many measures relate to dental care? First off, there's 1,000 measures in the endorsed NQF database. Anyone have any idea how many relate to dental care? 2, I heard 2. 6. Keep going. 14. And most of them relate to pediatric care. So this is a fundamental area that, that I believe this community needs to address, and I know you are addressing, is getting to the kinds of outcome measures that can drive value-based payment. Or even, to begin with, more process measures that will provide important information back to dentists and other health professionals about how they're doing. What kind of care are they providing? How valuable is it? Not just, what's the procedure that I've just completed? There was also a huge investment in the Centers for Medicare and Medicaid Innovation, $10 billion, that's, $10 billion, so $1 billion a year over 10 years to innovate. And it really helped to evolve the role of the Centers for Medicare and Medicaid beyond a check-paying organization to one that was using its purchasing power and also these resources to innovate. What's the analog on the oral side is really my question for you. Not really one. So how do you figure out what your leverage points are to get this kind of innovation going and spreading? It also catalyzed a lot of delivery models, and I'm going to talk about that. And then since the ACA was passed in 2010, there's been a whole lot of other bills that have passed. You wouldn't know it if you were paying attention to the national news. There actually has been quite a few bipartisan bills passed that have been building on this whole notion of moving to value for all sectors. The most consequential, I think, recently was the macro legislation, which is changing the way physicians are paid, away from solely fee-for-service to move more towards volume. Okay, part 2 of the presentation. So what has this meant for primary care, which I hope that you see a very close relationship with primary care, and I hope that we can get even cozier in the years ahead. So as all of this was going on, in the broader environment, those in primary care were feeling there was a lot of discontent about the hamster wheel that primary care physicians and other primary care providers felt really marked their really was the context for how they were practicing. Patients in and out, a volume-based system where they barely had time to spend with their patients and provide the kind of comprehensive care that they wanted to provide. They were constantly churning to get patients through to make their their nut for the month. So a lot of dissatisfaction on the physician side. We didn't know so much about how PAs and nurse practitioners were feeling at the time. It was really very physician-focused in the mid-2000s. A lot of dissatisfaction in terms of employers. They didn't feel like they could purchase the kind of primary care they were looking for. Is that happening in oral health? Is there dissatisfaction in terms of the payers with respect to oral health? I'll be curious if that's a phenomena. And patients were also not happy. And so what came out of that was a desire to envision a new kind of primary care. We called it the patient-centered medical home. In retrospect, we wish we didn't have home in the title because it suggests that it's actually a physical location. A lot of patients actually think it's a nursing home and they, run from it. So it's not the best name, but it is the name we've got. And I really want to give a shout out to the pediatricians. This model really came first, a program to make sure that kids with complex needs got all of their needs addressed, the patient-centered medical home. There's 5 principles: patient-centered, comprehensive, coordinated, accessible, and committed to quality and safety. And I'm really underscore the comprehensive because that's where I think the intersection is between primary care and oral health. When these principles were developed and we were getting consensus around them, the PCPCC was founded because there was an understanding, and it was radical at the time, in the mid-2000s, that the physician specialty groups alone, the American College of Physicians, the osteopathic physicians, the pediatricians, and the family physicians were not going to be successful in their reform efforts if it was just doctors talking to doctors. That it comes across as self-serving when it's just the profession. That you really need to make the case to all the stakeholders in healthcare that in order to reform, you need to get a consensus about what it is the new healthcare system should look like. And those that are paying for it and those that are receiving care need to buy into that new vision. And that was a really important lesson, and I think the most important reason why this effort has been successful in redesigning primary care was that multi-stakeholder approach. We termed it multi-stakeholder advocacy, and I know from my days of going up on Capitol Hill that when you come together and say, here's all the stakeholders that want this change, you're much more able to be successful than each stakeholder going up to Capitol Hill or to a state legislator or to the Medicaid director with their own vision. If you collectively have the same vision or advocating for the same thing, you are light years ahead. For those of you who don't know what a patient-centered medical home is, it's not a home. I mentioned that earlier. It's not a physical location, but it's a change in the way you deliver care so that it is more proactive in that a practice understands who's the patient population they're trying to serve. Is there a particular, is there a large percentage of people with diabetes or asthma or cardiac care, and then targets their care towards those patients. So you have to have data and registries and analytic capability to be able to do that targeting. It's also more customized. And so you don't wait for someone to walk in the door. You say, have you had your foot exam? Have you had your eye exam? Good diabetic care requires all those things. And what gets the practice moving in that direction? It's the performance measures that look at how you're doing for that particular patient population and for that particular patient. It's also much more accessible so that you can get in same day, you can have an exchange with your PCP via email, via telehealth, mobile apps, etc. So it is really a revolution in how we deliver care and much more team-based. Not so much in 2007 when the principles first came out, but it has evolved. So the theory of change I've alluded to is, all the diverse stakeholders getting religion about what it is we're trying to achieve and working together on that. Private sector accrediting bodies saying, okay, any practice can declare themselves a patient-centered medical home, but what does that exactly mean? Meeting standards. So the NCQAs, the Joint Commission, the AAHC, URAC, states, health plans, all getting into the mix to define those standards and actually provide some incentives for physician practices to transform. And then we, as an organization and the broader primary care community, understood what our levers were. You know, saying to the employers, your contracts with health plans should be moving them to PCMH. States, you can put legislation in place to move health plans and Medicaid into PCMH arrangements. And then we worked a lot on the federal front through legislation and with CMMI around innovation. We've evolved this vision of primary care, and we introduced the shared principles of primary care. So 10 years after we first had the joint principles, we introduced the shared principles, and they reflect how the evidence base has grown, what we now know about what contributes to value. Person and family-centered care is much more robust. We understand how important it is to get patients involved in shared decision-making, changing their behavior to get better health outcomes, even designing practices. Comprehensive and equitable. We always had comprehensive, but it's much more articulated now. We also have a focus on addressing the social determinants of health. Team-based. It's interesting to look at the 2007 principles. It was as if nurses didn't exist or PAs. That's no longer the case. On my board, I've got the nurse practitioners. In our membership, we have the PAs and the pharmacist and the entire team. That's absolutely critical. Also high value. We're all stewards of a very precious resource, and we need to be focused on that. And so in particular, for comprehensive primary care, when this was built out in 2017, there was an explicit inclusion of oral health. So that really is a change from 2007, where that was not called out and now is. And I'm very pleased to be able to tell you that. More work to do to make that a reality, but there is a recognition that oral health is part of comprehensive primary care. So, some success. Yet challenges remain. Let's first talk about the success. We don't have a comprehensive database of PCMHs, but looking at across all of the databases that do exist, we conclude that there's more than 20,000 patient-centered medical homes across the country. More than 1 in 5 primary care physicians is now practicing in a PCMH. Not sure about NPs and PAs. And the evidence base for the value of PCMH continues to grow. And that's absolutely critical, because if you're going to say to payers, invest in PCMH, pay more for PCMH, you need to be able to demonstrate that you're going to get better quality and lower costs. Lots in the peer-reviewed literature. I've left some of these on the back table. We do an annual review of the literature. It might be something that you begin to pull together as you go on this journey to demonstrate, in one place, the programs that are improving quality and reducing cost. In 2017, when we released this, there was 1,500 journal articles about PCMH in the literature. We culled that down to about 50 that met our very stringent requirements, and I'll show you in a minute that you'll see PCMH definitely reduces cost. For the most part, has improvements in quality. You'll see a decline in ED visits and inpatient utilization. We are proud of these statistics, but not fully satisfied. We think that PCMH can do a lot more, and I'll explain why we think it hasn't been as successful as we know it can be. We also, last year, did a report to understand how does PCMH fit into the broader universe of accountable organizations, and we looked at accountable care organizations and discovered that, and there was really very little, or actually no research beyond case studies about this. what we found is that accountable care organizations, which is a virtual organization that is focused on a set of outcomes where they are somewhat at risk payment, although not enough in my view to actually change the delivery system, those that were most successful in terms of achieving lower costs and higher quality were ones that had a solid foundation of PCMH. And so this was a very important finding that we shared with the administration, and it has, I think, influenced their thinking about how to evolve the ACO program. So what are some of the challenges that we continue to face? I mentioned earlier that, the performance results are good, but in our view, not good enough. There is still a chronic underinvestment in primary care. And this statistic is not well known or understood by really informed health policy people that I encounter on a regular basis. I would just love a show of hands, and please don't be embarrassed. How many of you knew that we spend in this country 5 to 8% of the total spend on primary care? Now, you're public health people, so maybe you did know. Right. Everyone thinks it's higher. Gosh, you've had these patient-centered medical homes. God, there's been all this focus on primary care. 5 to 7 cents on the dollar. Well-functioning health systems in Europe, double that, and some of them are closer to 20%. They understand the value of prevention and health promotion and management of chronic illness so it doesn't become acute. The integration of behavioral health, addressing addiction, the integration of oral care. But you can't do that in 5 to 7 cents on the dollar. So we have made progress, but we still are stymied by this underinvestment. And while we are moving to value, a lot of performance-based payments, some PMPM, so upfront payment to take care of care coordination and care integration. Still, by and large, the bulk of how primary care physicians are paid is fee-for-service, and that's toxic. Because you're paid to do, you're not paid to keep people healthy. So we're on this journey as well. I recognize we're further along than you are, but we've got some headwinds and we're not where we need to be. Because of this payment system and because of the lack of investment, we have these persistent silos. Would we like to be providing comprehensive care? Absolutely. But instead of a full-fledged team, we've got a teamlet, a physician and an MA. That's not comprehensive care. So lots of work to do there. And we're facing, as you are, lots of changes in the marketplace with consolidation, retail clinics, telemedicine, smartphone care. I mean, a lot of that can be very positive if we can integrate it because it provides more accessible care for patients. It's much more convenient. But it also has the real potential to further slice and dice primary care instead of make it more integrated. And that's a real challenge that we face. So we've had to evolve our theories of change, given how the market is changing and also this persistent underinvestment. I mean, there's only so far we can go with that kind of investment in primary care in terms of transformation. So we're now focused on working with states to get more investment into primary care so that we can have a richer PCMH model. And I don't mean richer in terms of getting the PCPs paid more. I mean, a full-fledged team with an array of services that patients are looking for. That's what I mean about enrichment. One of the poster childs for this, and I know you mentioned it in your remarks, is Oregon. Oregon first started with patient-centered medical homes and a Medicaid waiver where they offered a much larger array of services to Medicaid beneficiaries and actual linkages into the community. They demonstrated unbelievable savings through PCMH and the CCOs. They made a case to their legislature that they should compel health plans to also do this in the commercial sector, and they were successful. And so Oregon, Rhode Island, Delaware, they are all models, and we are working with other states that are trying to put this in place. Interestingly, the health plans will tell me privately that it's very difficult for them to invest more in primary care because of the dynamics in their market. And so if the legislature is compelling them to do that, that's a whole other story. You know, when you think about these comprehensive models, we are saying to the state legislatures that they should include behavioral health integration. They should consider oral health, and that's where I think we can do some more work together. We're also advocating directly for more primary care-oriented benefits. High deductible health plans have been very problematic for primary care. Middle income, low income people, even higher income people, when you're facing a deductible of $1,200 or $5,000, you're not going to go for that primary care visit, and we've seen a decline in primary care visits. So what's happened with benefit structure has been very problematic. We're looking at models that are carving out primary care from insurance and having employers directly contract with primary care. Again, lots of experimentation to figure out how we can continue to evolve the delivery system. And finally, we're focused on this, you know, a couple of places where we can really work on this integration, and behavioral health is one of them. I mean, given what's going on in the broader environment with addiction, and particularly the opiate epidemic, and with, you know, suicide, this has become a very important focus area for the PCPCC. We've just launched last year a behavioral health primary care work group, and we are actively working to further integration. Yes, it is further along than oral health, but still they suffer from the same kinds of things that you do, you know, separate delivery systems, separate payment systems, separate training, lack of integration, and yet we know how much, you know, what's going on with your mental health affects your physical health, and we're learning how much what's going on with your physical health affects your oral health and vice versa. So, you know, patients are not body parts. Patients, you know, need to be treated in a comprehensive way, and we need much more of this integration. Okay, now we're going to focus on the third part of the presentation, which is oral health. And here's where I'm going to need a lot more of your help to understand the dynamics that you're facing and how what we've learned from, you know, the overall movement to value-based payment, what my organization and all the leaders that are involved with it have helped to spearhead, and you know, what we've accomplished and what our challenges still are. So what does this all mean for oral health, and how can this be applied to what you're focused on? You know, when I look at what's going on with oral health, I wonder if it's a tale of two cities. You've got some improvements, but then some, you know, enduring problems. And so success, but, you know, still challenges. Seems like you're under a lot of pressure to reduce dental costs and provide more value. Same with medical care, and, you know, it makes sense. Most expensive healthcare system in the world. You know, continued, you know, we don't have universal coverage yet, though we're moving in that direction, and we fall down in terms of quality. We got to do better. Growing dental practice consolidation, you're not consolidated as much as is true in medicine, offers lots of opportunities, but also some challenges. Lots of care being provided in new settings and technology-enabled modalities. I was really interested to hear your remarks about, you know, meeting patients where they are. We think about this a lot, healthcare without walls. You know, we need to go to the patient as opposed to expect the patient to come to us. My kids cannot understand why you would have to go to a primary care office or a dermatologist. I mean, can't I just take a picture and, you know, send it in and get whatever care I need? Like, really? I mean, they don't go anywhere. They don't do bricks and mortar anything. Why would they do it for medical care? So, that's the mentality of the millennials. And, will that remain once they start to develop conditions where they need more of an ongoing relationship? I don't know. I mean, I think they're going to be very comfortable getting a lot of their care in many other ways, and we've got to be prepared for that. I mean, we can't be thinking bricks and mortar. We've got to be thinking meeting the patients where they are and what their needs are. And also, you're facing, as we are, a lot of workforce changes. So part of this is, pressure to drive down costs and gain efficiencies, but how can we think about team-based care in a new way, and the dentist as a very highly trained part of the team, but not obviously providing all that care, and how can we really spread the care better across the team? So, I mean, if I think about lessons that we've learned that could apply to what you're thinking about, is my question to you: do you feel like you have a shared vision for the future of oral health? It's wonderful to see so many diverse members of the care team, and that's a huge step forward. What about folks who are other kinds of stakeholders? The payers are here, that's great. You probably want to have additional payers, employers. Where are the patients? And I don't mean to put you on the defensive, but that has been truly transformative for our work, is to include the patient in the conversation. It completely changes the dynamic. What do patients want from oral care? How do they want it integrated with the rest of their health care? Talk to the patients. It really can change your view. It also can help you get beyond a lot of, oh, we can't do that. Because it's hard to say to the patient, we can't do that for you. It really is. I've seen, lots of clinicians figure out how to work together because that's what the patient wants. That's what their needs are, that's what their preferences are. That's what will improve their care. Thinking about these models and what the implications are, your vision and what the implications are for care delivery and payment. The performance measures we talked about, I'm going to do a little deeper dive there in technology and the workforce. So a little deeper dive. This is something that I saw in a white paper that came out of Qualis. Is this citation, Oral Health, an Essential Component of Primary Care, is this white paper something that is familiar to this group? Seeing some nods. Okay. I thought it was very well done, and not just because my organization has endorsed it, but I think it really is a very helpful articulation of the kinds of things that primary care could do to further oral health. And so you see that's where the intersection is. And it helps to get that specific. And so I would absolutely recommend this paper to you. Maybe your models evolved since then, but I found it to be very useful. And I also want to call out Judith Haber from NYU, who's familiar to you, and also Anita Glicken, who helped to inform this presentation, but also are part of the PCPCC and very involved in our work. So you need the model of care, and you need some agreement about the model of care in terms of this integration with primary care. I think it then helps to be very specific about, what's the role for primary care. And I look at this framework and I think, well, this makes so much sense. This is really what primary care does in relation to all the other specialties, and how it provides that first line of care, and then, if necessary, hands off to the specialist. And many, for lots of things you need to hand off to the specialist, but at least can do that first line of care. Again, we got to figure out the payment system so that primary care can potentially have a dental hygienist on staff, or helping to do that care integration. And again, I don't know if I'm stepping on, in sensitive territory? I have no idea, but you'll tell me. And, if so, that's a real conversation. Let's figure out, how do we do this integration? So your measures, 14 out of 1,000, obviously more work to do there. Need to focus on diagnosis so you can have a denominator, and so you can understand what your performance is. Got to get beyond the procedural codes. Need measures that look at clinical process is a great place to start. Care coordination, patient experience. Is there a dental patient experience survey that exists like there is for the medical side? Does one exist for oral health? A standard patient experience survey? I'm saying no. Okay. That's a great place. That's a great place to work. And as you said earlier, really the holy grail is to get to those outcome measures and those cost measures. Medical started with process, eventually got to patient experience. Maybe you can move faster than medicine has. It's been, 30 years developing these measures. I know that there's work underway with ICHOM to develop patient-reported outcome measures in the oral health space. Fantastic. Hopefully that can move more quickly than it has moved in medicine. We have too many measures, but not the right measures, and we don't have enough outcome measures is the basic, storyline for medical care performance measures. Learn from our lessons, please. Obviously, the role of technology is essential. Standard electronic health records can help in the collection of measures so that doesn't all fall to the dental health team. Helps to share information across settings of care. Patient portal, so people can get information without having to call your front office. Clinical decision support. Obviously, technology is very important. I don't know that there's been enough investment in that, and I know you were not part of the big investment that happened on the medical side in terms of electronic health records. So again, the positive side of that is hopefully you won't repeat the same mistakes, and we'll figure out interoperability that we're still working on. Education and culture, critical. We want people to practice differently. They need to be trained differently. We know that, but that's much easier said than done. I know that there are some online training that already exists for those in practice, to help, for example, primary care clinicians feel comfortable in doing, sort of the very basics related to oral health. We need more partnerships between medical and dental schools in terms of education. We need a lot more clarity around the roles and responsibilities of team members. But if we don't get this right, we know that all of these changes may come to naught because culture figures out a way, to eat strategy for its lunch. Care delivery won't happen unless you really have the buy-in of the team. And so this piece is absolutely critical. But I would say we have found that payment reform, at the end of the day, is the hardest nut because you are moving money around, and you're not going to increase the pie. In fact, the pie is, needing to get squeezed, and in that kind of environment, you're shifting dollars, and so when you move somebody's cheese, that's when things get a little bit hairy. Pilots. Evaluating the results, promulgating what is working, working with folks like DentaQuest sounds like they're doing quite a lot, and they have so much spread on taking successful models and getting them spread, I think, and other payers as well. It was really important. And so I think I've really touched on most of these. I'd say I want to leave you with also, think about collaborating with the PCPCC. So 60 different organizations from all parts of healthcare. We do have dental health representation. We have one dental health organization. We'd certainly welcome others joining our membership. We have 8 dental organizations that have signed on to the new shared principles of primary care. If your organization is not signed on, it's a wonderful way to start the conversation about how does oral health fit into the broader healthcare system, healthcare delivery system. Encourage you to sign on. I would love to do a webinar on, an innovative program that integrates dental health and primary care. We could do it next month. I'm just telling you, we just got an opening for February. I will bring to the planning committee for our conference in November a population health focus, and I'd like to incorporate dental health if we can. I have influence, but I don't make the final decisions about what gets into our program. I think there's lots of ways that we can work together moving forward. Thank you very much. Okay, and we have some...
Can you talk about how this information, this messaging is being handled within the medical education structure, the pre-doctoral structure? I say that because the vast majority, and I'll just throw out a number, it's probably as high as, in my mind, about 85% of dental schools don't go near this subject matter whatsoever. So we keep producing generation of practitioners for whom this type of information is foreign and is probably even threatening. Are you doing better in medical education to prepare the workforce to at least be open to these types of concepts and practice modalities?
I think we're... When I was at the National Academy of Medicine, Institute of Medicine, I actually I was the lead staff on the health professions education report. So I was much more on top of how things were at that point. I understand from talking to those in the field that it has evolved and that there's a growing understanding and that it has had some effect on training. But I think there's a ways to go. I remember talking to a Kaiser Permanente medical director who said that it actually takes them 4 years to inculcate a resident to think differently after they've been through a traditional training system. So it remains a challenge. My personal view is that the federal government could use its lever, in terms of funding medical education to drive change, and they haven't chosen to do that. That's a $10 billion investment every year, and we have no performance metrics associated with that. So again, I think that the education system needs to the major payers need to take a page from what's happening in practice in terms of, using their purchasing power, insisting upon certain attributes that they want from the system, translating those into performance measures, and then paying on that. But, that's a longer conversation. And you're right, if we don't train people in the beginning, it's much more difficult down the road. Now, you educators may, maybe other people want to comment on that or offer their views.
Thank you for your wonderful presentation, Anne. As well, you focused on the underinvestment in primary care, but you could also turn that, flip that and say there's overinvestment in tertiary care. And what has been done to reduce the cost of tertiary care, end-of-life care? Also, what is being done to adopt models of training of doctors outside of the United States, to adopt that here in this country so that we don't have to pay for 4 years of college prior to going to health professional training programs, A lot of the people in this audience have trained as dentists in other countries, but they come here because the opportunity for economic opportunity is greater when they're providing tertiary oral health care.
Yeah, a lot more work there. And so we focus, we are very careful in our messaging to focus on how do we enhance primary care to improve population health and reduce costs. And, if you play that out, it's going to be a shift in where you put your dollars and an emphasis on care that's upstream, not downstream. But if we, wanted to go and change the ruck that sets the payment level, we'd run into a buzzsaw. So clearly, the specialists and the hospitals continue to have, the lion's share of clout in the healthcare system. And it's only going to be the payers, the employers, the government that can work to shift that balance of power. There's, efforts underway, like who's heard of Choosing Wisely? Okay. So Choosing Wisely is an effort to get the health professions and the specialists in particular to identify those things that maybe we shouldn't be doing in medicine. And it's had some effect. We've actually worked to bring the patients into that conversation, because if the doc is saying, we shouldn't be doing this test, we shouldn't be giving you this antibiotic, no, you don't need this MRI, but the patient is, thinking that that's optimal medical care, we've got a problem. So we're working on the patient side of that, that conversation. Yeah, and I think our training is too long. It's very different than most other industrialized countries, and they have better health outcomes. Now, lots contributes to that, but we can probably take a look at our training and all the costs that incur for our graduates of being in such a long and intensive training.
Hi.
And I think AI is going to change a lot of this.
I brought that up at breakfast this morning, AI. I think AI is going to be a big game changer.
Yep.
And what I've learned also, this IoT, which is, I only learned about this phrase 2 weeks ago. And I'm saying, holy cannoli, I think that's going to change things. And then I think as a profession, dentistry needs to hold the mirror up and say, we've met the enemy and here we are. For many decades, we as a profession have been pushing back from Medicaid, Medicare, what have you, because that's just the model that was created way back when. And as Kaz, Dr. Evans mentioned too, we've been affiliated with dental schools that have pioneered the effort of recruiting, retaining, and putting into the marketplace healthcare professionals that want to make a difference, that want to deal with underserved, that want to integrate within the healthcare system. And I think you're absolutely right. That has to happen. But I have a comment. It's wonderful, and I admire what you and your patient-centered primary care collaborative is doing. But in looking at the board of directors, I saw a couple of attorneys, a couple of MBAs. I'd love to see an oral health professional on there. So that's my little nudge. There is not one on there.
That's true.
But you are committed, and that comes through loud and clear. So thank you, sincerely. I would like to suggest that possibly to help use some assistance in promoting the conversation and getting this oral health. It blows my mind. Vision is not that's primary care, but yet look at all the special stuff there. Behavioral health. I love the way you mentioned in one of the goals having nutrition as part of the dental thing. A number of us have been promoting that for years. Where does food enter the body? The mouth. And we have dental hygienists who I hold in very high regard, that to me are the best health educators in the healthcare business. And they're underutilized because they're not reimbursed. And I think those kind of systemic changes too, to start to integrate at the very basic level with the patients similar to what you're suggesting, I think is awesome. And then my personal suggestion, please consider adding an oral health professional to your board of directors. I think that might be helpful.
Thank you.
Thank you so much.
Additional questions? No.
Thanks for a great presentation. Wanted to get your comments on what's been a market-based solution to a problem in healthcare, which is CVS Minute Clinics. They work. They do great. Comments about that as a solution to your primary care medical home?
Yeah, no, it's a great question. Before my time, when the retail clinics were just rolling out, CVS was invited in to have a conversation with our board about, what does it mean that you're going to be launching these retail clinics? There's now 11,000 of them across the country. And they committed that they would make sure that the care that they provided was integrated in terms of communicated back to a PCP, and that they were basically filling a gap. Now, I think it may, and so we have their CVS leadership commitment that that's happening. I think it happens in some markets and maybe not so much in others. But they are filling a gap in terms of accessible after-hours care. Like, we need to recognize that. When I had a sick kid who had a earache, and I could go to the CVS at 10 at night rather than the emergency room, that's a better option. So how do we, recognize these other settings of care and make sure that it gets kind of integrated back in? But now we're at a new level, because now we've got CVS Aetna. And so we had Troy Brennan, the current CMO of CVS, come to our board meeting in July, right after that merger was announced, and it looks like it's going to go through. And he laid out, a plan for how they want to help in the management of chronic conditions. So, once we're all wearing, these devices that are tracking a lot of the data that give insight into what's going on with our chronic condition, and you can be going, communicating that data. Does it go to the CVS Minute Clinic? Does it go to the primary care physician or primary care team? Where does it go? So I think it's all of a sudden going to get even more complicated and interesting. But we need to continue to go back to what is good for the patient, and what kind of care do we achieve the best outcomes and the lowest cost.
I think we have time for one more question, if anybody has one. Or comment? Okay. Well, thank you so much. This was wonderful.